Can you guys see it?
So this, yep. So you have to control it, I guess?
Yeah, sorry.
Yeah. Okay. You can go ahead and, next slide. So this is a talk I actually give our fellows just on what are the qualification requirements for non-invasive ventilation, and then what do these different modalities mean. And then I discussed a little bit about sort of the knobology of home vents and, you know, bi-level machines and when to use them, when they're appropriate. Next slide. So there's this like alphabet soup, just like with invasive ventilators, non-invasive ventilation. And so we'll go through what these different settings mean. Next slide. So when you're talking about, you know, qualifying someone with COPD, neuromuscular disease, hypoventilation syndromes, when you're looking for those guidelines, you know, they don't call it home ventilators, or they don't call them, you know, bi-level machines. Medicare calls them respiratory assist devices. So when you're trying to, because you'll never remember what these qualifying guidelines are. So if you're looking to initiate a patient, the easiest thing to do is type in Medicare qualification guidelines, respiratory assist device. Next slide. And so when you look at them, that there's non-invasive positive airway pressure therapy, and then there's, which is kind of just CPAP. And then you have your respiratory assist device. So that's your bi-level therapies. And the HCPCS code is E0470 for like a BiPAP, which is a spontaneous mode. Anytime you add a backup breath rate, that makes it E0471 and adds thousands of dollars to the cost. So you really want to make sure they need that when you're ordering it. Next slide. So, you know, there's different criteria based on whether you have a restrictive thoracic disorder, hypoventilation, COPD. Actually, we'll just skip to the next slide. And the next slide. Next slide. Next slide. So this is what you use for COPD when you're trying to qualify a patient. So you need an ABG that demonstrates hypoventilation while they're on their prescribed FiO2. It has to be an arterial blood gas. Medical insurances will not accept venous blood gas for this PaCO2 requirement. As you can see there, it's got to be greater than 52 millimeters. You have to have oximetry that shows just some hypoventilation, and that is on their home supplemental oxygen. And then now you just a disease process. So as you can see, you can actually, depending on how they do, there's two different situations where you can get one of these devices. And when you see these patients in follow-up, you have to just discuss, is this relieving their symptoms? And, you know, put that in your note. And then they have to be adherent to therapy. So, you know, all these devices you can download and see, you know, what the usage is, how are they using it. There's actually a lot of data you can get. And, but you have to document, obviously, in the closet, right? So, and then these are some of the devices over here on the right. So remember, sometimes people get confused on a VPAP versus a BiPAP. Remember, BiPAP is like Kleenex. It's, you know, Kleenex is a copyrighted tissue. So BiPAP is copyrighted by Respironics. So when you talk about a BiPAP machine, that's a Respironics machine. So for bilevel therapy. ResMed is variable positive airway pressure therapy, but again, it's just 2 levels of pressure that the patient gets. Next slide. Hello?
Hey.
Next slide, please. So let's say you have a 31-year-old male with a history of obstructive sleep apnea on CPAP at 6 centimeters, referred for from neurology for worsening respiratory status, dyspnea on exertion. Clinical findings in muscle biopsy were actually consistent with adult onset SMA, spinal muscular atrophy, which usually presents in the 2nd to 3rd decade of life. And molecular genetic testing with a targeted mutation analysis confirmed this diagnosis. You can see the pulmonary function testing there. Next slide. What would be the most appropriate treatment in this patient as far as NIV goes? So just continue on CPAP, but give them a little bit more positive airway pressure. Just put them on an auto bilevel mode. Just put them on BiPAP 10/5 to give a little bit of augmented ventilation. Consider a trial of volume assured pressure support or adaptive servo ventilation. Alphabet soup and everything of these different therapies. Next slide.
Oh.
So I would argue, you would support. So this is considered a bilevel setting. But what happens is you set the lower number, the EPAP, to control the apneas, and then you actually, instead of giving and dialing in an IPAP, you actually prescribe a tidal volume. And so what these devices do, they're going to change that pressure support or change that IPAP to ensure that a specific tidal volume is delivered. And it can be important, patients with neuromuscular disease that's going to progress over time. If you just put this patient on BiPAP 10/5, that might give them an adequate tidal volume and minute ventilation for a while, but as their respiratory muscles become weaker, as their disease progresses, it's likely going to be inadequate. So with this volume assured pressure support mode, it actually compensates for that progression over time. And a lot of times we'll do this in our COPD patients. Actually, we just are completing a project where we looked at patients who've had multiple hospitalizations for COPD and actually discharged them on a volume assured pressure support mode. And the idea behind that is, COPD, 1, tends to get worse, and 2, when they're having one of their flares, increased airway resistance, a lot of air trapping, this will actually compensate for that decrease in minute ventilation and inadequate respirations they have, and actually rests the respiratory muscles. Next slide. So again, this kind of different modes of non-invasive ventilation, which can certainly be confusing. That's why I give this lecture to our fellows. Next slide. So CPAP, it's continuous positive airway pressure. We use it most commonly for sleep apnea. It just gives, it essentially acts as a pneumatic splint to keep the upper airway open during sleep and address sleep apnea. Next slide. So it's continuous positive airway pressure. And this is the guy who actually invented CPAP, Colin Sullivan. He actually got the idea when he was vacuuming his floor in Australia and said, I wonder if I could just reverse the engine in this vacuum and actually push pressure in. Because back then there really wasn't much you can do for sleep apnea other than just, doing a trick. And I always argue that George Lucas beat him to it with Darth Vader's life support system. Next slide. So this was the first ever CPAP titration study performed by Dr. Sullivan in 1980. And this was a guy who was he worked on skyscrapers in Sydney, Australia, and his friend found him asleep dangling off the 40th floor of a building. So he obviously needed treated right away. So this was the very first CPAP. This was the first portable CPAP that someone actually got sent home for. And you can see, I mean, it was a huge contraption. These devices have become a lot smaller over time. Next slide. So CPAP, you know, is the most widely used form, and again, it acts as a pneumatic splint. It can counteract auto-PEEP and can reduce the respiratory muscle load and the work of breathing. It can have an impact on patients with overlap syndrome, which is COPD plus sleep apnea, and patients with obesity hypoventilation syndrome. Sometimes simple CPAP will improve their CO2 retention over time. Next slide. A lot of times now we'll use Auto-CPAP machines. So these newer machines actually have algorithms that will detect variations in airflow and the degrees of airways obstruction. So you can potentially do a home sleep test and then have an Auto-CPAP prescribed, and it'll and have your sleep apnea treated that way. Next slide. And I went over the difference with BiPAP and VPAP. Go ahead and click forward. Again, BiPAP is a trademark name. So bi-level and VPAP are the same. So bi-level positive airway pressure and variable positive airway pressure. But again, they both have an IPAP and an EPAP. Next slide. And so these are two common devices used, you know, the Respironics BiPAP S and the Res S. Those are actually older devices now. Next slide. And again, this just shows the difference between CPAP and bi-level, where there's not, you know, the CPAP, there's not a big change between the inhalational pressure and exhalational pressure versus BiPAP, where you see that difference. Next slide. So again, variable positive airway pressure and bi-level positive airway pressure are the same. They deliver an IPAP, expiratory positive airway pressure, and an EPAP, which is the expiratory positive airway pressure. And that gradient between the two is the pressure support. And the IPAP also acts in reducing the work of breathing and fatigue and reducing the workload of the muscles. And the EPAP is the really main reason to have the EPAP is to maintain upper airway patency. You know, IPAP is what you use to really target sort of minute ventilation and ventilate patients. Next slide. These are adaptive servo ventilators. So what these are used for is really Shane Stokes breathing. That's why they were actually developed. And you see this pretty common in heart failure patients with CNS disease, and it really does a good job of sort of smoothing out that crescendo decrescendo pattern of breathing, which can lead to some pretty significant sleep disruption. There was a study a few years ago now called SERVE-HF, which using these devices in heart failure, and it actually found there was a higher mortality in the group with a EF below 45%. So you would never want to prescribe one of these devices in patients with systolic heart failure. Next slide. There is a VPAP that is specifically programmed for COPD. These patients obviously have some prolonged exhalation, air trapping, and hypoventilation. So really to maintain synchrony and comfort, these patients can be challenging. So this has a sort of default setting where the rise time, which is how quickly it gets from that EPAP to IPAP, is quicker. So they spend less time and so they have plenty of time to exhale. They have a high cycle sensitivity, so it's really sensitive when the patient wants to exhale, and it has a shortened TI max time, so they spend less time at their inspiratory pressure. Next slide. So BiPAP ST or VPAP ST, so these are static bilevel therapies, but you're just adding a backup rate. So S stands for spontaneous and T stands for time. So just like invasive ventilation, the BiPAP's going to cycle and deliver that IPAP if a patient spontaneously breathes and triggers the bilevel, or if a certain amount of time based on your backup breath rate passes. So if you have a patient that you put on a backup breath rate of 10, they're going to get a breath every 6 seconds. Right. So we use this pretty frequently for sleep disordered, complex sleep disordered breathing. Again, not Cheyne-Stokes respirations. Sometimes we'll use this in CPAP emergent central apnea that doesn't correct over time. And we previously used this mode sometimes for hypoventilation syndromes. We'd give them a big delta or pressure support between the IPAP and the EPAP with a backup breath rate to ensure adequate minute ventilation. But with home ventilators now and volume assured pressure support, we do that less frequently. Next slide.
Dr. Stansberry, is this an place to end?
Yeah, okay, yeah, we're past time, huh?
We're just right at it. If anybody has 1, 2 questions.
Anyway, yeah, anyone have any questions?
Dr. Doyle, I think you're muted.
All right.
In the case, Rob, what was SMA, the disease?
Spinal muscle atrophy.
Thanks.
Yep.
Thank you. All right, guys, if you have any questions. What?
I was just going to say that was an actual case we saw.
Oh, cool. We're right at time, so if you guys have any questions, send them to me and I'll make sure Dr. Stansberry gets them. We are postponing the next session that would fall on the 21st. So our next meeting will be November 4th. I will send out that reminder as well, along with all the other stuff I'm going to send out today. Let me know if you guys have any topics you want to add to that list, and I will get them on there. And I think that is all I have.
I would say one more thing, the Breathe Easy podcast from the American Thoracic Society, I just got a ding about it. It's actually this month an update of reimbursement and educational curriculum for pulmonary rehab in the United States. So it might be a good thing to listen to on your commute.
Awesome. Definitely. Perfect. Thank you, everybody. Everybody have a wonderful week.
Take care, guys.
Thank you, Dr. Stansberry, for coming to the rescue.
Yeah, sure.
Thank you. Thank you. Bye-bye.
Bye.
Thank you.
Bye.